you can't do all of these things like I'm talking about. And you mentioned the EHRs, electronic health records, the remote care. All of those really have an analytic component to them. And what I saw over the last 3 or 4 years being involved, for example, in remote care, is the differentiation of the remote care vendors was not about the device that was in the home or how easy it was or cheap it was or none of that. Okay, it really was what's the back end look like. There were two things that we're looking at as we move from the Beacon grant, for example, to a full-scale remote care deployment within St. Vincent Medical Group, and we were looking at how well were the protocols developed, you know, in the vendor, and would we have the ability to customize those, and the analytics. And as we began looking at much of the health IT, it really focused in one of the major contributing factors that would differentiate vendors was their analytic capability. Now let me say this. The disappointment that I've had in my CMIO career has been in the electronic health records inability to have good analytic tools. I really thought that was going to be the answer. Been very disappointed in that. And I think you're seeing that nationally because you're seeing companies that have sprung up virtually overnight, last 4 or 5 years, that have focused on this issue of analytics because there was a void that needed to be filled. Not only were the EHR companies kind of slow coming to that realization, but there was, in their defense, there was this whole problem of lack of interoperability. So the problem that electronic health record deployment has is that it doesn't have all the data. And the data on a particular patient, if you're aggregating data to the patient-centric level, or even population level, is that much of that data is outside the purview of the organization, the healthcare organization, the enterprise, so to speak. And this is where health information exchange can be very helpful in terms of being able to give you that data, but much of the country is not served by health information exchange. So what we're seeing is the ability of these companies, business intelligence is another name, but analytics and clinical analytics, is the ability to take disparate data from legacy systems, from EHRs, from registration billing systems, and now, as we talked about, even remote care, because that generates a lot of data, right? And to be able to aggregate that and to map it, normalize it, that's not an easy task to do. And some do it much better than others. And even the analytic companies that have gained some notoriety are limited, many of them, because they're really only taking the claims or administrative data, the billing data, and not the clinical data.
There's not a marriage.
And it's so important to have the clinical data. And again, that's a differentiator among the analytic companies. But what we're seeing now, and the surveys of CIO through CHIME and other organizations, and many of these surveys now are saying that the #1 target now for CIOs and organizations, and healthcare organizations, is analytics. And in getting the right type of analytic to this, not so much the data warehousing piece, it's really the analytics. And you don't necessarily have to have both, but they're starting to focus more on the value of the analytics. Well, why is that? Well, one is you have to get all the data, right? And that includes the clinical data, which is very difficult at times, okay? And you need to do that. You need to do the normalizing, mapping, et cetera. Most of that's done remote hosted now. It's in the cloud, so it makes it easier. You don't have to do it all internally now, right? So, but you need that, and then you need the predictive.
That's what I was thinking. Yeah.
Okay, and then the third area will be the prescriptive, which we aren't even scratching the surface. But that would be having all of it at the point of care to make your decision. But right now, even if we could get predictive capabilities on the data within an organization, within a population, Now getting back to, for the example we talked about, who needs the remote care? Who would benefit most? Who needs certain types of rehab? Who needs certain types of therapies coming out of a hospital stay, or now to prevent a hospital stay?
So, for example,
So that's the predictive capability that most organizations don't yet have. I'm sorry.
the interesting piece of that too would be the timing of the predictive capability, so real time or not. So, for example, rapid weight gain, which you would see in remote, let's say after a CHF with a rapid weight gain, then you know there's an alarm that needs to take place there, because actually an intervention could be as simple as an increasing a medication.
Yeah.
So,
altering the medication dose, right.
and so, I mean, right there is a good example, I think, of the predictive that you're referring to.
Well, and you don't, that is a good example, but a lot of that with good clinical personnel, nurses or LPN or trained, specially trained or whatever, and you can have an escalation protocol. You don't really have to have predictive for that, because that's well known that if the weight goes up, then you need to adjust the medications or do other interventions. The predictive power would be, let's say you are now the clinical director or executive director of an ACO, and you've got 20,000 covered lives, or 50,000, whatever that number is. It would be to take the population as an aggregate and know, using your claims data, but even more importantly is using your clinical data too, and marrying those two, and be able to say, we have this many diabetics, we have this many people with hypertension that's not controlled, or diabetes that's not controlled, we have this many people who are overweight and smoking, you know, all the things that we know are going to be bad outcomes. And it could be within a month, 6 months, a year, or whatever. But to have the capability and the power to be able to say, here's where resources are needed, here's where our highest costs are going to be, and that's at the population, the aggregated level, and then to be able to drill it down even to an individual patient level and say, this patient has these 3 conditions, and we know that if we don't do something for him or her and try to intervene, we know what the natural outcome is going to be. And we know how costly that's going to be for our organization, because now we are at risk. Totally different than fee-for-service, because in fee-for-service, you know, traditionally, we have targeted who needs to come in and have a procedure done. This is avoiding those procedures. A
complete paradigm shift.
Avoiding those heart attacks. You know, avoiding those amputated extremities and diabetics that are poorly controlled. So there are so many things that we could. And again, being a primary care physician all my career, this is the way I wanted to practice medicine. This, you know, but there was you would have starved if you practiced medicine in this manner, because that's not the way the system was geared. It was to treat illness. But I think all good primary care physicians in their soul really want to improve the health of a population that they serve, whether it's, you know, 2,000 or 3,000 patients that on their panel, or if they're part of a larger organization that is serving 50,000 or 100,000 patients, whatever that number is. It is, what are the tools? And today we have them. What are the tools that would make it better for me or my organization or my group to serve this population? And guess what? A lot of that isn't related to procedures and to, you know, if I see them more, if I do, it's really related to a lot of the kind of the non-medical treatment. So it's diet, it's exercise, and it's the access to healthy foods, and it's access to transportation, and a lot of the things that really doctors traditionally have not had an impact on, and providers, but now they're taking on that responsibility. So some of it is technology, but it doesn't have to be all related to technology.
I think an interesting thing has emerged is, several years ago, I was the founder and president of Medical Animatics, and our focus was patient education and engagement. An area that we specialized in was bariatric surgery and, the lifestyle change that was required for addressing the obesity issue. And I think now what's interesting is that there is a direct-to-consumer play, and that's starting to emerge in sort of the new economy of healthcare, if you will. But to go to your point about data, what's very interesting is you mentioned that data from the clinical side, the data from the claims side, sort of the business data and making that analytic connection. But now today, there's all this wearable technology and all this people starting to get engaged in their own sort of measurement of what they're doing on the wellness side. And another interesting paradigm that's emerging is the employer's play in that. So not just the patient, but also the employer. So what do you think is there? And I know also you have an interest in sort of working with innovators around this space. So talk about that for a minute. What do you think the future is in wearable on that side of the data piece?
Well, you bring up a very important point on wearables. There are several areas, and I'll explore that with you. We're at a interesting paradigm now between who owns the data that's coming from all these wearable devices, number one, and who's responsible for that data. And then the third, which is, who's going to pay for this? And is there an ROI? Because a lot of people are debating that right now. So just touch on a few of those points. Many people, including myself, feel that the data that someone generates and they're wearing a device, that they own it. In fact, I feel that they own their data that's in their electronic health record, too. I think the patient owns the data. But in many cases, particularly now with the Fitbits, the Jawbones, all the wearable devices that are out there, and the many applications that have been built around these, there's a disconnect between the collection of that data and the assimilation of that data on the provider side, because the providers are pushing back and said, I don't want all that. I can't manage that. I don't want to be legally responsible for that either. So there's this raging debate that's going on right now is who is responsible for managing that information. This gets back to the previous discussion we had on the patient engagement or the patient activation. So if a person has purchased, now we'll call them the consumer, not the patient, but if a consumer has purchased these devices and they are wearing them and they're getting certain types of results, what does that do in terms of changing their behavior? Well, hopefully, optimistically, you would say it would help them. It would make them walk more, take more steps. It would if they're having trouble with their sleeping patterns, for example, they may want to curtail their alcohol or caffeine use, etc. All right. So, how much of that can take place independent of the provider? And in my view, the answer is, well, the provider has to be connected to it in some cases. So again, if we're talking about population health, now you have the means by which you can actually quantify and document either what's good or not good and what's bad in a patient's daily life, which we didn't have the opportunity to do that as providers in the past. We had to rely totally on history, and we know sometimes that's not real accurate because patients tell you what they want you to hear.
What they think you want to hear.
Right. And my patients, I'd have them record their blood sugars and their weights and things like that at home. Well, they'd bring in a list, but they only wrote down the ones that they wanted me to see, right? Well, now we have the ability that we can capture these more accurately through these devices remotely, all right? And that's a positive, I see. Okay, now, where the providers are pushing back, which is understandable, is that I'm getting overwhelmed by the amount of data, and I can't physically have enough hours in the day to manage all this. Well, the answer to that is you don't have to. And that's why we need to reorganize our whole care delivery as teams and away from that everybody has to be seen face to face. So now if we organize teams and on the provider side to maximize their interaction with a population of patients, whatever that panel size is, it could be 5,000, could be 10,000 patients, whatever the size of their practice, what are we going to put into place? Well, there are some people who want to go out and buy a wearable just kind of for the fun of it. I mean, it's for their own experience, and they'll manage, and I just let them do that. But if it's prescribed, and it would be of benefit for people, let's say, that are overweight, you use bariatric, but maybe not even that far. If they're just overweight and they're hypertensive and they just need some help, well, I think the provider then for that particular type of patient needs to be looking at the data, helping analyze the data, giving advice, and most importantly is giving the education that they maybe wouldn't get on their own.
Sure.
So you can divide it into, let's say there are three groups. There's kind of the young, healthy, the worried well, and let them just do it on their own. There's on the other end of the spectrum are these chronic disease patients that we talked about that need a lot of help, and they need a lot of technology and interaction and virtual care and a lot of attention paid to them because they are the most expensive patients, right? All right. And then there's this huge group that's in between, that are people that are not yet burdened by all this chronic illness. They're working every day. They're productive. But they are looming disasters if we don't do something. Okay, because they smoke, they don't exercise, they're overweight, they may have bad family histories. We need to focus and put resources into that group. But the big question is, we don't know what the ROI is for that because it's a long-term decision. And because of the way insurance works, people are, through their employer predominantly, are in one plan this year and then they change jobs or they're another plan. So you can invest in a lot of that, and that's where these wellness programs haven't really shown an ROI. You can put a lot of investment into that as a payer or as a provider who's under risk, but the benefit may be 5 years from now, 10 years from now, in terms of what you're avoiding. But I think that as we, again, move around this payment reform, more and more people and organizations are going to realize that they have to do it. They have to find the common ground where the benefit is real and will come back to them by investing in the health of certain individuals in the prevention mode.
Yeah, wellness and prevention.
And health and wellness prevention, which has had a lot of attention paid to it, but again, the data doesn't prove its value as well as I think it will in the future when that population health management becomes so critical. I
see a lot of employers really getting into the game now, and that's a cost avoidance model as well, trying to figure out, okay, how do we inform our employee base? I think it's a really fascinating time of change in that space as well. But again, it comes down to that's a cost avoidance model, and as an innovator, a health IT innovator, you're thinking through sort of what's the business model, the revenue, resource, and all that. It's really hard to predict where it's going to head.
It is.
Because it's just like a perfect storm. Everything's swirling around. We're not really sure yet where it's going to land,